Both pieces and the BPSD algorithm actually have a basis in geriatric assessment approach and geriatric psychiatry. It is what we do, is part of our assessment process, just slightly different ways of sort of approaching it. So you've got, I don't know if you can log on, you can go back to www.bpsd.ca to bring up the algorithm on your smart device. The flow chart, you'll notice, has blue typing. Anything that is blue is a hyperlink. So if you click on the blue, there's content information behind the blue. It'll take you to the algorithm that's in the scrolling form. It's pretty self-explanatory. You just have to play around with it. All the information basically is there, and it's broken up into two parts. So there's part one, part two. And we talked a little bit about part one, which is the assessment piece. It's all the information that we've talked about with respect to pieces and a lot of the non-pharm stuff. The second part gets into medication, use for behavioral and psychological symptoms that may respond to medication. Highlights what those are, and then Barb's going to go over, I believe, the drug table. So it's all that information is there. With respect to BPSD and medication, you have to know if the person's got a problem that's going to respond to medication, and is it serious? So when it comes to, for example, psychotic symptoms in somebody with Alzheimer's disease, for sure you want to get a sense, is this severe? Is it dangerous? Is it distressing? Is it disturbing? Is it having an impact on how I'm reacting to others in my environment, and potentially if it's persistent? And it hasn't theoretically responded to non-pharmacological, use that broad term again, interventions. What often happens in mental health and psychiatry is this conversation when it comes to the drugs. What is a chemical restraint? Chemical restraints are medications used with the specific intent to reduce a patient's mobility or promote sedation beyond that required to establish a normal sleep cycle. We all deal with sleep disorders. That is a primary issue in mental health, and especially in folks who have more advanced dementia, and a high percentage of people with obstructive sleep apnea. And we do sometimes try to work to establish somebody's normal sleep cycle, and sometimes that does require medication. This should not be confused with medications used to treat drug-responsive behavioral/neuropsychiatric symptoms associated with specific medical and psychiatric diagnoses.